So, as Professor Kostic said, I'm fond of Serbian culture, so I'm slightly intimidated today to talk about my small things in front of you. And since I'm going to talk about imaging, I would like to start with a few images from Serbia, which I like most. First of all, this guy, I wouldn't be here without this guy. This is Nikola Tesla, who invented MR, so I wouldn't be here today without Serbian people. But I'm not only fond of Serbian science, but also from Serbian culture in general. So I like many of the people that produced the work here, from Ivo Andrić to Crnjanski. Sorry for the pronunciation, but he wrote a great book, Migrations. And the other two guys that are closer also in look to me, like Emir Kusturica and Bregović. So, thank you. So moving on to my part now, from Serbia to Italy. I will talk about the use of MR in clinical neurology in terms of diagnosis, the first part, and in terms of understanding disease pathophysiology in the second part. Of course, I can't review for you all the possible applications of MR techniques in these two fields in 45 minutes. I have to be very strict to 45 minutes because the organizing committee was very strict to me. So I will review just a few conditions on which we work most, which is multiple sclerosis, dementia, especially Alzheimer's disease and frontotemporal dementia, Parkinson's disease and related conditions, and motor neuron disease. So I will go through each of these four conditions in the two bullets that I showed you before. So starting from diagnosis, I think that you all are aware that now we can use MR to establish a diagnosis of MS very early in the course of the disease when the patients present with the first symptom, and we can show using MR dissemination in space and time. We have international accepted criteria to show subclinical lesions that allow us to make a diagnosis earlier and more confidently than a few years ago. And the same is true for dissemination in time. We are using formation of new lesions or the presence of gadolinium-enhancing lesions. We can, from the first day of clinical onset, establish a diagnosis of MS, which is incredibly important for starting an immediate treatment, which is critical for the future evolution of the disease. Work is ongoing in this field to try to improve this criteria even more. So one of which is to assess, in addition to white matter lesions, also cortical lesions, gray matter lesions. We did this work a few years ago, where we showed that if you use double inversion recovery sequences to pick up cortical lesions, you can improve the diagnostic accuracy of the model with a 4-year follow-up in CIS patients in a quite reasonable way compared to previous criteria. And this is mainly due to the fact that you increase specificity, which means that if a patient starting with CIS, suggestive of MS, has already a cortical lesion, this is highly predictive that he or she has really MS. Because usually cortical lesions form late in the course of the disease, so if a cortical lesion is already present at the very beginning, it means that there has been a long subclinical period. I think that, anyway, the future will shift the paradigm to diagnose MS with the use of ultra-high field scanners, such as 7 Tesla scanners, where you can see stuff like this, for instance, a venule going through a lesion of MS, which might be the pathognomonic sign of the condition. So I guess that in the future, we will move from a paradigm which is based on quantitation, so counting lesions, to a qualitative paradigm where you will see some typical or even pathognomonic changes that are suggestive of MS. But this will come in a few years when ultra-high field magnets will be available worldwide. The same is happening in the field of dementia. I guess you are all aware that we can also the diagnosis of Alzheimer's disease is supported if you find something on imaging which is suggestive of this condition. For instance, we can now measure very well the hippocampi and show atrophy in the hippocampi, and not only in the general hippocampus, but also in subfields of the hippocampus, and especially in the CA1 to 2 transition area, as well as in the subiculum. There are changes that can be picked up also at the MCI level, which are very suggestive of the presence of Alzheimer's disease. In addition to this, of course, there is atrophy, which is much more distributed across the entire brain in Alzheimer's disease patients, that can be picked up using voxel-based morphometry. And in addition to this, we have PET imaging with typical FDG PET for glucose metabolism, showing reduced metabolism in the posterior cingulate and the precuneus, as well as in the lateral parietal cortex, which is extremely suggestive of the condition. And more recently, we also have the possibility to image amyloid deposition with PET using PIP-PET. You can see that patients with Alzheimer's disease do have a signal showing that there is a lot of amyloid which has been deposited in their brains, which is not seen in elderly normal people. So all of this has entered clearly the diagnostic criteria for Alzheimer's disease. Also in frontotemporal dementia spectrum, we are changing the scenario. And in this case, it seems that the white matter damage is very relevant to improve our ability to make a diagnosis. This is a set of studies that we did assessing the different pathways related to language, and for instance, in the PPA variants of the condition, and with typical pattern involving specific tracts in every of these conditions. But the most important part is that you can also get information at an individual patient level to make a diagnosis. For instance, patients with semantic dementia do have a typical involvement of the left inferior longitudinal fasciculus, which allows, for instance, to distinguish them in 98% of the cases from non-fluent conditions. And also this is true for other tracks and other variants of this dementia. And I want to reiterate that this is not group analysis, but this is individual patient analysis. So this might be very helpful in clinical practice to contribute to the diagnosis. Same is happening also in Parkinson's disease. As you know, MR is not very useful. Conventional MR is not very useful in Parkinson's disease. Nuclear medicine techniques are much more used and much more diagnostically important. But something is happening in this field as well. For instance, again, using ultra-high field strength, you can have a very nice pictures of the midbrain with a clear depiction of the red nuclei or of the substantia nigra. And this is a normal case. And if you perform ultra-high field scanner in patients with Parkinson's disease, you can see that the lateral margin of the substantia nigra is undulated, which is never seen in healthy people. And you can see this both in early and in advanced Parkinson's disease. So this might be a fingerprint of the disease, which might be very useful for the diagnosis. And by the way, the amount of these undulations is related to the clinical manifestations of the disease. So even in Parkinson's disease, MR is changing the landscape. And as you know, also in Parkinsonism, we have now linear measures to assess the size of the pons to the midbrain and the cerebellar peduncles, which have been shown to be very useful in a ratio to assess, to distinguish between different PSP patients and between them and Parkinson's disease. And the work done in collaboration with Professor Kostic, we added to these linear measures also as we assessed the diffusivity changes in the supratentorial and the frontentorial brain of patients with PSP. And if you add the linear volumetric measures to these microstructural damage measures, you can improve the diagnosis at the individual patient level again quite a lot. For instance, compared to this more conventional approach, if you combine the two, you can improve by roughly 100% your ability to distinguish between Richardson syndrome and PSP Parkinsonism, which is a very complex scenario in daily life practice. The same is true for motor neuron disease, where, for instance, in addition to measuring what happens in the corticospinal tract, you can assess what happens in the corpus callosum. And corpus callosum is involved in all motor neuron diseases, but it seems to be more involved in PLS than in typical ALS. And again, you can distinguish these two variants of the disease, assessing diffusivity changes within the anterior part of the body of the corpus callosum, with pretty good precision. And also, this is again work that we are performing using support vector machine to help in distinguishing patients with different phenotypes of the disease. And again, you can say that using large samples of patients and a clever approach, you can very well distinguish among conditions that might be challenging in a clinical situation. So this is all I wanted to say about diagnosis. I will focus a little bit more on understanding disease pathophysiology, because this is the largest part of my activity in the last 30 years. And the first point was to try to understand what is associated. I worked most at the beginning in MS, and then I met Professor Kostic, so we moved also to neurodegenerative conditions. So I will start from MS to move to other conditions. So since many years, one of the major issues is to establish which factors are associated to disability progression in MS. And we know now that all of this might be involved, and this is why conventional MR scans findings are not so much related to the clinical manifestations of the disease, because with conventional MR we just measure white matter lesion load and location. We don't know much about all the rest which is present. Advanced MR techniques are allowing us to study all of these different factors, and I will focus on a few of them for the sake of time, starting from the damage to the normal appearing white matter, which is very well studied now using tractography, diffusion tensor imaging and tractography. This is a study that we did in our lab showing the different topography of damage in different white matter tracts associated with different phenotypes of the disease. You can see that whatever is the onset of the disease, so as CIS or primary progressive, you do have already corticospinal tract damage. And then when the disease moves on to the progressive forms, you have additional damage, including significantly the corpus callosum and several other frontoparietal areas that might be the substrate of cognitive impairment, which is seen in many patients with the progressive form of the disease. And in this field, I think that a major work has been done by our friend Shaki Sarlota Mejaros, who worked with us 2 times and for 2 periods of time. And this is just to show you the powerfulness of this technique. She measured several tracts in the brain, and she tried to correlate them with the overall cognitive impairment and impairment at different neuropsychological tests. And she used a complex mathematical framework, which is called random forest analysis, to rank which of the many different variables was most important to explain cognitive impairment overall and in different domains. And she showed that the damage to the cingulum was related to overall cognitive impairment as well as to performance at different tests, almost all tests, with an ability to explain the variance of cognitive impairment, which was close to 80% or more. So again, a technique which allows you to open a sort of window on the general brain damage in patients with MS, which might be a simple measure to assess many patients, for instance, in the context of clinical trials. Gray matter damage, we improved a lot when these sequences were available. These are double inversion recovery, which allows to suppress the signal from the white matter in the CSF, bringing out lesions in the cortex, which are, of course, related to the cognitive impairment of these patients. But even most importantly, these lesions, in a set of studies that we did in collaboration with a group in Padova, are associated and are predictive of subsequent disease evolution in terms of locomotor disability as well. As you can see, these are a large group of people with different MS phenotypes, and you have different variables that explain 2 to 5 years later what will happen in terms of disability accumulation. And in all cases, you have damage, you have the amount of cortical lesions among the independent predictors of subsequent disease evolution. So these lesions are really relevant in our view to understand MS, not only in terms of cognitive impairment, but also in terms of more general terms of locomotor and disability accrual. And so we focused more and more on the gray matter damage, and we used an approach which tried to pick up damage both considering lesions as well as degenerative damage due to secondary Wallerian degeneration or transsynaptic degeneration. So we used advanced MR techniques after segmentation of the gray matter to understand the whole damage present there. And we have a set of studies that are going on in our lab with a relatively long follow-up, where we always showed again that gray matter damage is among the independent predictors of locomotor disability accumulation up to 8 years before. So these are two studies that have been published a few years ago. They are prospective studies which are ongoing, as I said. So we recently had the opportunity to reassess this cohort at 13 years. So this is a long-term follow-up, I would say. And we assessed what predicted accumulation of locomotor disability 13 years in advance. And this was just a baseline gray matter atrophy, which was able to correctly classify 70% of the patients as progressor or non-progressor more than 10 years before. And if you move on to cognitive degeneration, the situation is even better, because the combination of gray matter damage with the baseline disease duration was able to classify correctly progressors from non-progressors in 97% of the cases. So almost all patients were correctly classified 13 years in advance. Of course, in MS, there is also cortical reorganization, which is perhaps a way that the brain has to counteract structural damage accumulation. And there are this part of the story can be assessed using functional MR. And this is one of the many studies using task-related functional MRI to assess this aspect. And this is a study by Dr. Rocca in our lab, where she contrasted patients with different MS phenotypes to try to understand, despite the study being a cross-sectional study, to try to understand what could happen in a longitudinal fashion. And this is what she showed. At the very beginning of the disease, you have to perform a simple motor task. You increase activation. You over-recruit the contralateral primary motor area, as expected, as it happens also in normal people. With more disability coming in, you start to recruit also the ipsilateral primary motor area, the SMA, and the recruitment of the contralateral area increases. With more disability, you start to recruit other parts of the sensory motor networks, such as the S2 and the thalami, and this might be still be compensatory. At the end of the story, when you have advanced secondary progressive MS, to move a hand, you have to activate almost the entire brain in a sort of an erratic way, especially involving the frontal lobes. So this is not very much related to the motor network, so you might assume that this is not compensatory anymore, or even being detrimental, because if you have to move a finger, you have to activate the entire brain for the entire day, you might feel fatigued at the end of the day, as it is the case for patients with MS who frequently complain of fatigue. So there is a sort of natural history of cortical reorganization that we still need to understand, which might be relevant to compensate. It's a double phase situation where it might be very useful to compensate for accumulating tissue damage at the beginning and might be useless or even detrimental later on in the course of the disease. Of course, we have also resting state or resisting state fMRI, as it was called today in a previous session. But a resting state fMRI can be obtained in patients with no collaboration from patients. So you have the information about the activity of the brain at rest, and you can pick up several networks that are active when you rest. And the most important one, which is related to self-consciousness and internal memory, is the default mode network, which is this network, which is typically involved in Alzheimer's disease, but it is also damaged in patients with MS. So we decided to study patients with primary and secondary progressive MS, so the most advanced patients where collaboration could be poor. And so where using resting state functional MRI, you might get information on their brain activity without asking them to do anything. And indeed, they showed a damage to the anterior nodes of the default mode network, which is different from Alzheimer's, where you have damage to the posterior nodes of the same network. But most importantly, this was related to damage, to structural damage to this, to the cingulum and the corpus callosum, which are, of course, the white matter tracts connecting these areas. But even more importantly, this correlated with their cognitive performance outside the scanner. So suggesting that we can get information about the cognitive environment of patients with MS, even if they are very disabled and not collaborative to perform a task-related functional MRI. The advancement in this field is the use of resting state functional MRI and graph analysis. Graph analysis is a mathematical complex model which is well beyond my ability to understand. So I will show you just what I understood. You can do several things using graph analysis and resting state functional MRI, one of which is to create hubs. So hubs is airport terminology, meaning big airports where you have many flights taking off and many flights landing. And so, for instance, now this is the situation in the globe with air trafficking. And so this is a set of connections relating different places. So like it happens in the brain, where you have white matter connecting different nodes, gray matter nodes in the brain. So let's imagine that you might have big hubs, important hubs, and small airports, okay? So if you damage a big hub, you will have something like this, like JFK in New York. You will not affect only the New Jersey area, so you will not create troubles only to people living in New Jersey, but everything will be stopped, as we experienced a few years ago. So this is to say that if you damage a big hub in the brain, you will have troubles not only because you damage that specific hub, but because you derange completely the connectivity of the brain. Let's imagine that you close any sort of airport in Italy where I always have troubles to come to Belgrade. And so if you close Rome or Milano airport, you will have something like this. So nothing will change in terms of general connectivity. You will just have me getting nervous and nervous because hours passed away. So this is to make the point that you can have the same damage, but you have very different outcomes because you might damage important airports instead of Fiumicino. And this is what can happen in MS. So we created hubs in healthy people. These are the hubs that are seen in healthy people between 20 to 40 years of age, which is the typical age of patients with MS, at least when they start. And this is what happened in the brain of patients with MS. These are 250 patients, so it's a big study, pretty robust. And these two groups of patients are completely similar for any sort of variable. apart from the fact that these patients don't have cognitive impairment, and these do. So these are cognitively impaired. And I think that you can easily see that they completely lost all their hubs in the frontotemporal regions, so this of the left hemisphere. So this might be yet an additional factor leading to important cognitive impairment, because you're losing relevant hubs in critical parts of the brain for cognition. So similar story is going to be built for Alzheimer's disease. So we don't have CIS there. We have MCI, mild cognitive impairment, and the issue is to predict evolution from MCI to Alzheimer's disease in the same way, in the same vein we showed for MS. And we know that we can pick up at least 2 years in advance changes in the brain, especially in the medial temporal lobe, in MCI patients which predict who is going to convert from those who are not converting. And this has been confirmed by many studies, for instance, by assessing atrophy in a larger area centered around the middle temporal lobe, which allows you to create survival curves which are very predictive of subsequent conversion in a way which is even better than what you can predict using typical CSF markers like tau or amyloid, as it is the case in many clinics. But I think that the situation is even more exciting today, where we have studies performed in patients with family with a genetic Alzheimer's disease, autosomical dominant, where you can predict how much in advance you can see changes in some imaging features which are predictive of subsequent clinical onset of the disease. So we are talking here about elderly normal people or normal people, and what you can see year in advance which predicts subsequent disease evolution. So you can see that you have changes such as hippocampal volume that predates clinical onset by 15 years, as well as changes in deposition of amyloid in the precuneus, but even changes like the presence of CSF markers, which predates 25 years. So we have the ability now to follow up the preclinical phase and to understand the most intriguing part of these diseases, and to predate diagnosis, which might be critical to start soon treatment when available. Also in Alzheimer's disease, we were able to show white matter damage, and this is using diffusivity. What you see in color is what has been found to be damaged in the white matter of patients with Alzheimer's disease, but as well as in MCI. And the point that I want to make here is that if you pick up and you overlap gray matter damage with the white matter damage, so gray matter damage is in light blue and the white matter damage in red, you can see there is a sort of anatomical correspondence in patients with Alzheimer's disease, suggesting that perhaps at least part of the white matter damage is secondary to gray matter damage. But this does not seem to be the case in MCI patients, where you have this sort of correspondence in the hippocampal, parahippocampal regions, but you have a lot of white matter damage, which is not coupled by gray matter damage. So when we submitted this paper the first time, we got some crazy comments from the referees saying that essentially that we were crazy to show so much white matter damage before gray matter damage. But then later on, there were other people showing the same thing, and most importantly, they were able to show that some of the changes that we showed here were related to disease evolution, so they were clinically relevant. So albeit we appear a little bit crazy, we are not so crazy. Also in Alzheimer's disease, there is cortical reorganization, of course. And as I told you before, there are especially changes in the default mode network, which is damage in the posterior part. So this is perhaps the sign of a structural damage, which impairs the default mode network. And on the opposite, you have overactivity of the anterior regions, especially the executive and the salience network, which might be compensatory. And by the way, you can measure the full mode network size in patients with MCI, and already visually you can easily see that those who will convert to Alzheimer's disease already do have a very much smaller the full mode network compared to those who will not convert. So this might be an additional matrix to assess disease evolution, which has been confirmed by formal statistics. We did some graph analysis in patients with Alzheimer's disease as well, and this is the sort of connections that you can see in different nodes of the brain in patients with typical Alzheimer's disease compared to old controls. There is a typical reduction of connectivity in the posterior part of the brain as expected, and an increase of a small range connectivity in perhaps as a compensatory mechanism in a distributed pattern around the brain. I think that the situation is more convincing in early onset Alzheimer's disease, which is a more severe condition, more rapidly evolving, as you know, where we have a reduced connectivity around the entire brain, but the increased short-range connectivity, which is perhaps compensatory, is mainly seen in the parietal regions. And by the way, we have a very similar pattern of changes in terms of graph theory analysis in the brain of patients with amnestic MCI, where again we do have abnormal connectivity, especially in the temporal, frontotemporal regions, and an increased short-range connectivity in the parietal areas. Cortical reorganization happens also in frontotemporal dementia in a pattern which is opposite to that of Alzheimer's disease. So in this case, there is a reduction of activity in the frontal areas and increased activity in the posterior areas. So if you create a ratio between anterior and posterior brain, you can have a very good way to distinguish the two forms of dementia clinically on an individual patient basis. And we confirm this aspect studying several other networks in the brain. Again, the same story. There is a difference in the posterior-anterior gradient of network connectivity changes in the two forms of dementia. Of course, we have some sort of ludopathy. So when perhaps we have Parkinson's disease, so when we find a new game, we try to play this game ever and ever again. And so we did some graph analysis and assessment also in frontotemporal dementia, and as expected, especially in the left hemisphere, there is a complete loss of cortical hubs in patients with behavioral frontotemporal dementia compared to healthy people, with some also rearrangement of the local short-range connectivity. So the pre-last part of my talk is a few words on Parkinson's disease, where we are getting a lot of data from Professor Kostic's group. So I'm very pleased to show some of this data. And as you know, gray matter damage is not a major finding in patients with Parkinson's disease, apart from those with Parkinson and dementia, where there is a sort of pattern of atrophy which resembles in some way that has been seen in Alzheimer's disease, centered around the hippocampi. And but changes in the gray matter might be important also to assess specific manifestations of the disease, such as freezing of gait. This is work from Professor Kostic that we did together, where he showed that there is a gray matter atrophy in areas of the brain, especially in the orbitofrontal regions and in the dorsolateral prefrontal cortex, which are present only in those patients with freezing of gait and not in those without this sign. And this also, the amount of damage of atrophy seen in these areas is related to the frequency and severity of freezing of gait. White matter damage is also seen in Parkinson's disease. This is again diffusivity story, comparing again in collaboration with Professor Kostic, comparing moderate and severe PD versus early and mild PD. And you can see that when you move on from early to more severe PD, you really have a dramatic involvement of the, almost I would say, the entire white matter. And of course, this is an important observation, because if you wish to treat these patients in etiologically, with etiologically drugs, you should start well before this damage is so widespread and involving the entire white matter of the brain. White matter, which is also related to the clinical manifestations of the disease. For instance, we showed again together with Professor Kostic that there is atrophy of areas of the white matter areas, especially anterior, frontal, parietal, temporal areas in patients with the Parkinson's disease and the MCI compared to those with just Parkinson's disease. And again, this has been shown yesterday by Professor Kostic. Damage to orbitofrontal regions is associated to depression in Parkinson's disease. So I will not discuss this because it has been already discussed yesterday. And this has been discussed yesterday as well. There are, for instance, in patients with PD associated to GBA gene modification, you do have a much more widespread white matter damage than in those without this risk factor. So also white matter damage is present in Parkinson's disease, and it's also related to the clinical manifestations of the disease, or at least it might be useful to distinguish between different variants of this condition. So this is the last work that we are doing with Professor Kostic, assessing patients at the very early stage of Parkinson's disease to assess cortical reorganization. So we have hemiparkinsonism, so meaning that they have signs only on one side of their body, meaning that the other hemisphere is still healthy. So this is a good model in our understanding to understand what happens at the very early phase of the disease, in the subclinical phase of the disease, considering the healthy hemisphere still in the subclinical phase of the disease. So very briefly, because these are unpublished data that are coming out from the lab in the last few days, but I have to congratulate with Professor Kostic because he sent us thousands of patients, very many patients. So we are very busy to assess these scans. But the point I wanted to make is that in drug-naive hemiparkinsonism, you have an increased connectivity among the basal ganglion nuclei and a reduced connectivity from the deep gray matter to the cortex. So there is the reduced connectivity in the network where the disease is focused, which reduces the outflow to the cortex. We had the luck to have also some patients in the same phase of the disease, but who were treated with levodopa, and this is what you can see. Levodopa is able to reverse completely the situation, so the outflow to the cortex increases, and there is a increase the connectivity which was reduced among the different deep gray matter nuclei. So this is a good sign showing that treatment is able to re-normalize the network connectivity which was damaged by the disease already early in the very early phase of the disease. So this is, I think, a good experiment to show the powerfulness of fMRI to assess drug efficacy in an objective way. So the last point on Parkinson's disease is to show you also graph analysis here. And this is the, again, with Professor Kostic. We had more than 200 patients with Parkinson's disease. This is, again, unpublished data, so I guess that even Professor Kostic will see them for the first time. So there is, these are hubs in changes in nodal connectivity in PD patients compared to healthy people. Which shows that there is a sort of deranged connectivity throughout the entire brain. But if you split the group into two groups, so mild PD, you do have reduced connectivity in the areas that are associated with the motor networks, such as the SMA, and in the parietal, orbitofrontal, temporal, parietal areas, which are the typical areas that are hit very early in the course of the disease. If you move on to moderate to severe PD, you have these changes involving the entire brain. And by the way, if you put everything together, these connectivity changes again correlates with the clinical manifestations of the disease. So I end up with a couple of words on motor neuron disease, where we do have, of course, white matter damage, which is very important to be assessed from a diagnostic point of view as well as from a prognostic point of view. Of course, here the focus is on the corticospinal tract that can be segmented and assessed using diffusion tensor tractography. And this is a 3.5 years follow-up where we followed up these patients for this relatively long period of time and show that changes within, diffusivity changes within the corticospinal tract predicts not only the accumulation of disability in these patients, but also their survival with a specific value of fractional anisotropy, which distinguished between those who unfortunately died during the period of follow-up compared to those who survived. And finally, I want to show you again that cortical reorganization also occurs in patients with ALS, and it could be that it happens very early in the course of the disease, because we were able to show changes in functional connectivity only in a few areas of the motor network in patients with ALS, and only in those who didn't have yet measurable changes in the corticospinal tract. So this might happen very early, and perhaps before we are able to depict damage, but damage is already there, and with a sort of compensatory role. So I think my time is going to end, so I move on to the conclusions. So first conclusion is that I hope I convinced you that MRI offers useful pieces of information to achieve a diagnosis in many neurological diseases earlier and more confidently than on a clinical ground alone. This does not mean that clinics is not important. I'm just saying that if you couple a clinical assessment with MRI assessment, you will establish your diagnosis much better and much earlier. The second point is that we are lucky enough to have MR because it provides quantitative, sensitive to disease changes, pathologically specific, reproducible, and accurate measures that allows us to study in vivo the pathophysiology of the CNS in an unprecedented way. We were not able to look into our brain in this way just 10 years ago. Finally, we got to the point that the genesis and the onset of many neurological manifestations is not just a mere result of tissue damage, but rather it is a result as a consequence of a complex interplay between damaging and reparative mechanism. And so there is an urgent need to develop and validate multiparametric MR approaches to assess these different factors. And of course, all of this is central to speed up the development of experimental treatments amenable to modify the course of several neurological conditions. As we experienced in MS, I mean, we were able to produce MR markers that were able to allow a diagnosis much earlier and to monitor phase 2 trials much quicker, and to screen rapidly potential effective drugs to move on to the phase 3 trials, and of course also to monitor efficacy of drugs in daily life clinical practice. I have just one last slide, because a couple of slides. First of all, to thank the people working with me at the Neuroimaging Research Unit, especially two ladies that are very important. One is Federica Gosta, who is sitting here, who is leading the group on neurodegenerative conditions, and the other one is Mara Rocca, who is leading the group on MS and white matter conditions. And finally, the very final slide to thank, I started with Serbian culture, so I want to finish with Serbian culture and Serbian friendship. So there are many people I should acknowledge here. There is no space enough in one slide, so I will limit to 3, but the gratitude is to all of you. So first of all, Professor Kostic. I took a picture from the internet when he was very young, as he did yesterday for me. Of course, Jelena Drulovic, who is leading the MS story, and we met here for the first time discussing MS. So all I showed you today started from there. And finally, Charlotta Mezaros, otherwise known as Shaki, who worked with us and is a really great friend, and she established all the connections, or the graph analysis connection between Milan and Belgrade, despite Alitalia. Thank you very much.